One of the biggest things that we as a medical legal partnership wanted to do was reduce the number of emergency department visits because that's the highest cost incurred in the hospital systems.
Welcome to the Business of Healthcare podcast from the Center for Healthcare Leadership and Management at the University of Texas at Dallas, Naveen Jindal School of Management. Here at UT Dallas, we bring together business heads and other thought leaders to help navigate the challenges of our rapidly changing, increasingly complex healthcare ecosystem. I'm your host, Professor Dan Karnuta, Director of the UT Dallas Professional Program in Healthcare Management. Be sure to subscribe on Apple Podcasts, Spotify, or your favorite podcasting app to ensure you don't miss any future episodes. You can also join us online at businessofhealthcarepodcast.com. In this episode, we're going to dive into an interesting healthcare business concept that has been around for a while, but is not very familiar, if familiar at all, to most healthcare business folks. It's called the Medical Legal Partnership, or MLP. Now, I know what some of you are thinking. The first thing I thought of when I heard of MLP was Master Limited Partnership, which is a form of legal entity used when setting up a business. Well, the Medical Legal Partnership is not that at all. So listen on as our guest, Dr. Quinton Nottingham from Virginia Tech, unfolds the dynamics of the Medical Legal Partnership and how it can be used to improve healthcare access and quality and decrease the dreaded uncompensated care that plagues our provider businesses. Professor Nottingham is the head of Business Information Technology Department within Virginia Tech's Pamplin College of Business. He received his PhD, MS, and BS in statistics from Virginia Tech. Prior to his Virginia Tech career, he worked in the pharmaceutical industry at Hoffman LaRoche. Welcome to the Business of Healthcare podcast, Quinton.
Hi, Dan. Thanks. I really appreciate you having me on.
So let's start by, can you tell us a bit about your role at Virginia Tech and how you ended up getting into healthcare issues?
Well, Dan, I started, as you mentioned, I have a PhD in statistics, and I started, doing some research in non-parametric dose response modeling years ago. But about 8 years ago, I started working with some folks where we were looking at patient satisfaction, and we're studying patient satisfaction as a function of waiting times. And that was really interesting to me. And in doing so, we started branching out and looking at modeling cancellation and no-shows for patient appointments. And then ultimately, I was approached to talk about the medical legal partnership and help start and study one of those.
Okay, so what is a medical legal partnership and how does it work?
Well, a medical legal partnership is a collaboration between medical professionals and legal professionals with the overarching theme is to improve patient outcomes. And that is, we expect the medical professionals, whether it's case managers at Ballad Health, they have accountable community care navigators, have community health partners, doctors, nurses, what have you. When they interact with patients, you expect them to be trained to identify social determinants of health. And when they identify these social determinants of health, and I'll talk a little bit about that in a second, they refer the patients to our medical legal partnership. Now, social determinants of health, they are sort of environmental conditions where people live, they can be born in them, where they work, age, etc., that affect many aspects of their lives and their health, their functioning of quality of life, and any risks. So we sort of train the medical professionals to identify these social determinants of health. And when they see these with patients, they then refer the patients to the medical legal partnership.
So we're talking about population health at this point.
Mm-hmm.
So something that's near and dear to the hearts of the community-based hospital system. But I don't think it should be dismissed, certainly from the for-profit hospitals either, this type of partnership between the medical world and the provider or clinical world and bringing the two together to help serve patients better. So, Quinton, what's in it for the healthcare provider, for the health system, do you think?
Well, one of the interesting things with Ballad Health and what we've done, they've never particularly talked about finances or money. They really just wanted to take care of the patients. And Ballad Health has a their hospital systems are located in Northeast Tennessee and Southwest Virginia. And they have a catchment area of over 1 million patients, all in what we call Central Appalachia. And so many of their patients are low income, socioeconomically disadvantaged. And so they were interested in how can we help these patients get good medical care without going to the emergency department. One of the biggest things that we as a medical legal partnership wanted to do was reduce the number of emergency department visits, because that's the highest cost incurred in the hospital systems. And so being able to reduce that, or at least even if the patients are having these visits, that they visit when they're insured, is very helpful. And, research has shown that patients who are not insured, patients who are low income, rarely see medical professionals unless it's an emergency situation. So one of the things that the medical legal partnership is able to do is help these patients get insurance. And if they get insurance, or if they have insurance, they're then encouraged to, do regular follow-ups and get annual physicals and so forth. And so that it's not stressing the emergency department, it's stressing the hospital system.
So what a novel idea. Treating the patient better, reducing ER visits. So you're increasing your population health by encouraging patients to actually take care of themselves before it becomes an emergent situation, thereby reducing ER visits, emergency room visits, which, like you said, is a big cost to a healthcare provider, especially if you're treating uninsured or underinsured patients, and then you've got an uncompensated care problem. So for the provider, you're serving your population, certainly, but then you're also, as almost a byproduct, you are reducing cost and reducing the incidence of uncompensated care, which is certainly something that all providers are looking to do.
Dan, that's correct. And, initially when I met with Ballad Health, and this is late 2019 and maybe even midway through 2020, I met with their financial folks, and they were writing off presumptive charity as much as $10 million a month. And so, that's another reason, in setting up the medical legal partnership, we said, well, even though they didn't specifically talk to me about, hey, we want to reduce this presumptive charity that we're writing off every month, it's serendipitously is going to happen as if we get these patients insured, and if we can kind of encourage them to see the doctor on a regular basis, take your medicines regularly. And all of these things we ask on the intake form when we meet these and talk with these patients, how are you receiving medical care?
So Quinton, you mentioned Ballad Health. So tell us about your MLP with Ballad Health, how it's structured, who fulfills the legal part, et cetera.
Ballad Health, it's a hospital system in Southwest Virginia, Northeast Tennessee. And we're tracking, I believe, about 11 of their facilities for this medical legal partnership, to where we get referrals from the medical professionals. And Ballad originally funded us for 4 years, and they recently extended our funding for another 4 years. And so it starts with Ballad Health, and Ballad Health refers patients to our legal folks at Appalachian School of Law. So we have Appalachian School of Law, who handles the intakes from the referrals, and then Appalachian School of Law then refers the patients to either Southwest Virginia Legal Aid Society or the Legal Aid of East Tennessee, because we need to refer the patients to the right legal folks. And so we have 2 legal aid organizations that will help and create the cases and met out the cases for the patients. And then ultimately my involvement, Virginia Tech, or in my involvement with the medical legal partnership, comes from, we're the only MLP in the country that was actually started with a data analyst as part of that organization. And that is, I helped create the intake form, created many of the questions, so that when we analyze these data, we're not kind of going back and trying to get information. We're getting everything from Appalachian School of Law, de-identified, of course, but that allows us to sort of help learn who we're helping, how we're helping them, and what the needs are. So it's Ballad Health, Appalachian School of Law, the Legal Aid Societies of one in Virginia, one in Tennessee, and Virginia Tech.
This episode is brought to you by the Center for Healthcare Leadership and Management, the definitive resource for healthcare management education in North Texas. The center is based in the Naveen Jindal School of Management at the University of Texas at Dallas. It plays a unique role in training the next generation of healthcare leaders to meet local, regional, and national demands. The Jindal School uses its strengths in accounting, administration, finance, marketing, and information systems to educate highly qualified personnel for healthcare administration and executive leadership positions. The center is home to 7 healthcare leadership and management programs, including undergraduate and graduate programs, as well as executive programs for physicians and working professionals. For more information, visit us online at jindal.utdallas.edu/healthcare.
So the statistical part, the statistical information, the data, what's done with that data?
Well, I've created annual reports each year to kind of really get an idea of who it is we're helping. And we look at the awards that we win, so to speak, for the patients, the insurance that we help patients get, and ultimately determine a value, because we're helping patients get housing assistance. We're helping patients get food assistance. We're helping patients met out some legal situations. Ideally, or sort of a general acronym that's used when we talk about the medical legal partnership, is called IHELP, IHELP, where I is for income or insurance, H is for housing and utilities, E is for employment or education, L is for legal issues or help them resolve legal issues, and P is for personal family protection and stability. So as we're helping these patients and their cases are ultimately closed, we learn who it is we're helping and how we're helping them, because I then receive a case closure form that we created together with Appalachian School of Law from them to say how many hours were spent by the students at Appalachian School of Law, as well as the lawyers, and then the lawyers at Southwest Virginia Legal Aid Society or Legal Aid of East Tennessee. And so these data, they basically help us tell the story of how we're helping these patients and who we're helping these patients. And then a lot of research has been done on MLPs and questioning the medical professionals and the legal professionals. But in my research, I've seen very little to ask the patients how they were actually being helped. So the last part that I take care of and help with is I've created a survey to sort of evaluate the stress levels of the patients. What were they before they were seen or there was MLP intervention, and what were their stress levels afterwards? And we sort of send that survey out at least 30 days after their case has been closed, just to see if we've helped them overall, whether it's blood pressure reduction, cholesterol, and so forth. All of these things, if you think about patients who aren't insured, they add stresses that ultimately are adverse to their overall health. And so that's another reason why, the MLP has been very helpful to a lot of these patients.
So sounds like it's a 3-prong attack: clinical, obviously the health system; legal, some legal entity or society that is performing that function; and then, statistical, your end of things, which is it's great to do the first two, but if you don't have the back end statistics that you can then really employ the results from those to help make things better and concentrate your efforts on the things that do the most good, then you're missing a big opportunity. So can you give us some examples? You gave us some kind of high-level examples, but some examples of how the medical legal partnership works with patients or potential patients to improve the quality and access of their medical care, or like you said, their social determinants.
There are quite a few cases and examples that we've had over the years, because we've started this since January of 2021. And, looking at some of the data, it's fairly easy to see we've had patients who have had 2 visits that were uninsured, and some of these costs are at least $10,000. Some are significantly more than that, to the emergency department. And so they go to presumptive charities. And then these same patients, we can look at the data and see, they were uninsured the first 2 visits. And then the next 3 visits shortly thereafter, about 3 to 5 months later, they were insured. And then those costs, and we still associate the cost with these patients, are $20,000+. So instead of the Ballot Health actually writing off, $10,000+ for the first 2 visits, which they would have to do for presumptive charity because these patients were not insured. Then the next few visits, they were insured and their insurance paid. So that's an example of, just one of the pieces of the medical legal partnership actually helping patients get insurance. We've helped with housing insecurity. And that is, one example that I always like to use is there was a single mother living in an assisted apartment and was taking her child to the hospital, 4 or 5 days a week to the emergency department, thinking that the child had asthma. It was later learned that it was due to mold in their apartment. And the mother mentioned something to the landlord, got no action or reaction from the landlord. Then the mother was referred to a medical legal partnership. The lawyer saw the mother, wrote a letter to the landlord. The landlord put the mother in another apartment without mold, obviously. And the child never had to go back to the ER again because the child didn't have asthma. The child was inhaling mold. So that's another example of how the medical legal partnership can work for low-income patients. And again, it's pretty obvious, and the research has shown this, that low-income, socioeconomically disadvantaged patients, they're very reluctant to seek medical care. And many of them don't know the options that are afforded to them, whether it's via the legal aid itself or just through the medical legal partnership. And we've done, in my opinion, a good job in trying to reach out to folks to let them know what's available to them.
So I know in the for-profit space, for-profit providers, obtaining insurance is something that they'll have their patient access employees work on with patients that don't have insurance to reduce, obviously, uncompensated care. Like the patients in the emergency room, they don't have insurance, they may qualify for something. Let's put a resource on that to help them qualify. So when we treat them, we do have the possibility of getting paid. So that certainly goes on in the for-profit as well as the not-for-profit provider setting. But the social determinant piece that you're talking about, with your example of your housing and the mold there, it seems like that's going to become more and more important, even to the for-profit providers, when we get into the more risk-based, value-based pricing arrangements that are coming down from CMS and certainly are going to be becoming more prevalent in the future. Keeping populations healthy and keeping those high-cost, low-compensated patients out of the emergency rooms is going to become more and more important, really, to every facility provider. Well, Quinton, thank you for joining us on the Business of Healthcare podcast today and for sharing your experience with medical legal partnerships. You've certainly given our listeners something to think about, and myself included, when forming strategies around, like I said, population health and uncompensated care. It's just another, tool, another vehicle that's out there to explore.
Well, Dan, I really appreciate you having me on. We're almost a full 4 years into this, and it's really been a joy just to help patients and see the impact that we're having. As a researcher, we write papers all the time, and we rarely know the impact of this research. But this is an area of research that we're doing that we actually are able to impact people's lives for a very long time. So I really appreciate you having me on and making more people aware of the medical legal partnership.
Thanks for listening to the Business of Healthcare podcast. To learn more about the Center for Healthcare Leadership and Management and the healthcare management business degrees and certificates available to seasoned clinicians, master's students, and undergrads through the University of Texas at Dallas, go to jindal.utdallas.edu/healthcare.